and then we put the orders. I will show you about the admission. So there's a tab called admission here. So I'm logged in as in critical care. So when I go to admission, there is like a bunch of stuff here. The ones you need to care about is order reconciliation. So I'm just gonna go through the process, but I will cancel everything afterwards. So this one will basically tells you about the home medications. So you don't need to care about this right now. They will tell you about the current orders. So you just carefully go through the orders. Sometimes you will see, for example, you're upgrading a hypotensive patient and you see the patient like is on 2 blood pressure medication already ongoing. So you need to discontinue that. So you just like review, keep in the background why I'm upgrading this patient, let's say hypoxia. So you go through this and you see like a couple of narcotics. So you think, oh, this is decreasing his ventilation, so I need to stop the narcotics for now. You decide, mostly we continue the orders unless something is kind of like counterproductive in our problem right now. So we start to stop it. So probably I will just continue all of these. I'll just, there should be nothing yellow. You either continue or discontinue. So continue, things like that. I just keep doing it. I'm just doing it as I'm doing an admission right now, upgrading this patient. So continue, or sometimes you mention like discontinue something, vitamins you don't need. Sometimes like patient is already having diarrhea and he's on Miralax, so just discontinue that. I'm just like doing it randomly. You continue risperidone, you continue all this other stuff. Just like learn like doing these things quickly, and then once you're done, so you're reconciling whatever orders already on the chart, and then after that you will go and put your actual orders. So this is asking you to reconcile the prior to admission medications. So if you want to change anything, you can don't order this one, don't order this one. Anything yellow that you need to do something about it, you're not ordering this one. And then this is the actual thing. This is, you need to, I have my saved favorites, but if you guys don't have the same list, you might need to go here and put like an ICU admission order set. So you go to order sets, and then you just put ICU. I think it will show you ICU general admission order set, admission orders. So you go here and an order set will pop up. So it will ask you to put the code status. So let's say this patient is full code, cardiac monitoring, and then you go, you don't need to worry, like sometimes if COVID, just airborne, and then vitals. I have like a dot phrase, so I call like or call if. So I put it in. I have all my parameters plugged in, so I just accept that. You don't need to worry too much about the details. Activity progress as tolerated, and then labs. If sometimes like if there's no recent labs, you need like something now to know what's going on. So you have like all the stat orders ready if you want to order them. So I can put like, oh, okay, so I need to like a stat AVG, stat CMP, all this kind of stuff. If you don't need them, you will know from the paper you have like what labs are already collected on your chart checking. So if you have like a missing data point, you can decide if you want to order it now or not. Then you have the morning labs. You can order them from here, or you can do them afterwards. It's up to you. But you can put like at least like the BMP and the CBC and the MAG, for example, and the FOS. These kind of basics. If you think the patient is septic or septic shock, you can put lactic acid. This is kind of like 4 Q6 hours trend. Tropes, this is also like a Q6 hours trend. These kind of like basic stuff. Leave the other ones. These are PRN orders. Just leave them as is. Don't change them. And you can quickly skim through and then This is DVT prophylaxis here. You just put like enoxaparin or heparin. You can decide whatever you want. Like, let's see, this is heparin 5,000. So also, in terms of discussing the DVT prophylaxis, if we have like a risk for bleeding, we put like an anti-embolic stocking, which is SCDs. We can put the enoxaparin or heparin, depending on the renal function. And then there is two different strengths. So we have from Lovenox, we have 40 daily, we have 40 BID. This is what we call enhanced DVT prophylaxis. It's kind of like not low dose, it's like kind of moderate dose DVT prophylaxis. This is very important for you guys because for people with COVID requiring ICU, they usually be on the enhanced DVT prophylaxis. Most of the attendings think that way, at least from my experience. I'm not sure if, like, Samir, you have like a different.
Yeah. So most of the attendings will agree with this, but there is like some variation. Most excluding Dr. David Lee. He raises a very good point that there is no strong evidence to say this whole idea of doing enhanced DVT prophylaxis is mostly theoretical. There was some smaller studies, I think in Australia, and Omar's actually doing some research himself, I think, on this topic, but Dr. Lee is against it. So he says that you need evidence of you would need evidence of a DVT or a PE, and you would just do full dose at that point. He doesn't disagree that COVID patients have more VTE, but he does think that just doing the enhanced without like knowing is this helping or not is just not something that he likes to do. Other attendings use D-dimer levels, so this is like obviously in the setting of COVID only. So COVID patient, and then you have a D-dimer that's above 3,000. They see that as a slam dunk for putting them on enhanced, so Lovenox BID. But really, unless you have Dr. Lee, you could do the enhanced one for your COVID patients.
Yeah, and if you can see here, like there are if the patient have a normal renal function, you put Lovenox. If the creatinine is slightly up, you can opt for heparin. And the 75 3 times a day is the kind of like the moderate dose in the case of heparin. So this is the low dose, this is the moderate dose in heparin, this is for Lovenox. So let's say this patient is basically on Lovenox, for example, and then they usually ask you this standard question about like an LP or like some sort of procedure, like spinal procedure. You just need to mention none if it's actually none, which is most likely the case unless like you know your patient has have like a spinal procedure. There is like the stress ulcer prophylaxis. You can put Protonics 40 daily. This is kind of like a standard thing. You can put like a bowel regimen. Fever, some people have the fever, so I just put like a Tylenol 650. And then they will ask about the temperature. Just tell them it's 38 and above. Just like basic stuff. So you put DVT, you put like fever, and then you can go from there. You don't need to worry about all these kind of. It's kind of like overwhelming. They put like all the drips here, but you don't need to worry about them for now. You can put them individually afterwards. So by now, you basically put all the admit orders. So this patient is already admitted. So there was no actual admit on the top. But this patient will be transferred. So he's on the wards, we will transfer. So you can put transfer order. So you need to see the actual order where you actually put your attending on this patient chart. So this is how the actual admission happens. This is basically the service will be ICU, so put critical care, and then physician team, maybe ICU gold, for example. And then attending, let's say Dr. Evans. And then this is in CRMC, intensive care. I usually like used to miss this one. I feel like it's ICU versus intensive care. So you just put that in and then you accept. Once you're done, you're gonna sign. So this will basically admit the patient to the ICU. But you still need to think about what are you missing on this patient. Are you missing a certain workup? Are you missing certain antibiotics? This is just kind of like a basic stuff. Once you sign it, this patient will be upgraded to ICU. So let's say I sign it. Rather than that, I'll just like remove everything. Once I sign, the patient will be basically admitted to the ICU. After that, let's say we're talking about a COVID patient, which is basically my next topic. So far, you guys have any question about the like standard admission? I'm just wondering. Was that clear enough? Let me just open my lights. Yeah, you guys have any questions so far about like chart checking the patient, seeing, putting the orders, like how to go about the order set? Was that clear enough? Great. So now we'll go about COVID specifics, and I will tell you a couple stuff, which hopefully will be helpful. So you will try to see, so